Item of business is statement by Jean Freeman on health. The Cabinet Secretary will take questions at the end of her statement, so there should be no interventions or interruptions. And I call on Jean Freeman for 15 minutes. Please, Cabinet Secretary.
Thank you very much, Presiding Officer. Today, I want to set out the work that is underway to remobilise our health services. In doing so, I want to be clear about the factors that necessarily will limit our capacity to mobilise in the immediate term to the extent that we and patients across Scotland would wish. But first, I want to acknowledge the incredible and selfless work of all staff in the NHS and the social care sector and offer them my heartfelt thanks and gratitude for all they have done, often at great personal sacrifice, and all they continue to do. I know that the necessary pause on NHS services in the first months of the pandemic and the experience of lockdown, especially for the 180,000 people who rigorously followed our shielding advice, whilst undoubtedly saving lives, that pause also contributed to other harms to health. Whilst we were on track to significantly reduce waiting times, now the numbers of people waiting for a range of tests and treatments is rising, and will be added to by the unexpressed demand from those who have either not felt safe to come forward or who did not want to add to the pressure on our health and care services during the peak of the pandemic. This will be evident in mental health services as much, if not more, than in physical health, and it will be acutely felt by those who struggle with drug or alcohol addiction. I want to see all of these services and more remobilised. But there are real limitations to that, and I need to set these out clearly so they are recognised and understood. In recent weeks, we have seen real progress achieved in suppressing COVID-19 across Scotland. Numbers in hospital and intensive care have significantly reduced, and there have been no deaths registered from a confirmed virus case since the 16th of July. But there must be absolutely no doubt that the virus remains as virulent and as dangerous to life as it has ever been. Today, we are managing a number of cases, clusters and outbreaks across the country. These are all at different stages, each one being actively managed through the exceptional work of our NHS Test and Protect teams, led by tried, tested and highly skilled incident management teams. But each one of them is a clear reminder to every one of us that COVID-19 is an ever-present threat. Our aim is to vigorously suppress the virus to the lowest possible level. Full lockdown helped take us towards that, but full lockdown cannot last forever. So as restrictions are lifted, we need other tools that we can use, a comprehensive set of public health measures of intelligence, anticipation, prevention, mitigation and response. No one intervention on its own will do the job that we need done. On Monday, we published our testing strategy, updated since the early days of the pandemic. It sets out our current priorities for testing based on the work we've already done to increase capacity and improve availability. These priorities are testing all those with symptoms, hunting down the virus through testing close contacts of people with COVID-19, and using testing to prevent or minimise new outbreaks. Routine testing for people who work in high-risk environments, such as care homes, and we're also using testing to ensure the safe resumption or continuation of NHS services, and crucially, to assess the prevalence of the virus through a significant expansion in our testing for surveillance, both in our communities and in key sectors, including schools and hospitals. Our testing capacity continues to increase, and we should have the ability to test 50,000 people per day by the end of August, with further contingency capacity of 15,000, taking us to around 65,000 by winter. Today, we've published on the Public Health Scotland website the success rates of the National Contact Tracing Centre in making contact with those people testing positive and their close contacts. The new case management system for Test and Protect began rolling out to health boards on the 22nd of June over a 30-day period. The report we've published shows that between the 22nd of June and the 16th of August, 99.7% of all cases were identified as requiring contact tracing in the case management system were successfully contacted. Based on that work, the teams also traced more than 5,000 contacts, and they were successful in contacting 98.8% of those individuals. I would like to congratulate all involved in that achievement for their contribution to keeping us safe. As we approach winter, we plan for and deliver the seasonal vaccination programme for flu. But this winter, with COVID-19 still prevalent, the seasonal flu programme becomes even more critical. That is why we're planning a major expansion of that programme to vaccinate just under 2.5 million people before the end of the year. That's 840,000 more than last year. To those already eligible, we will add social care workers, NHS staff, household members of individuals who are shielding, and all those aged 55 and over if they are not already eligible under another category. We will then look to vaccinate those aged 50 to 54 if vaccine supplies allow. To vaccinate that number of people across Scotland in 3 months, and to do that safely with PPE and physical distancing in COVID-protected environments is clearly challenging. Detailed delivery plans are being drawn up, multiple sites identified, all to be in place and staffed and ready to deliver, making it as easy to access as possible in our cities and towns and in our remote and rural communities. And knowing that we must also be ready for the COVID-19 vaccine, so much effort is going into producing and we all hope for. Without doubt, we have reached this point in tackling the virus thanks to in large measure, to NHS and social care staff across Scotland. But that has come with a cost to them. I fully recognise the impact this extraordinary period has had on their health and well-being. Health protection teams, who are among the first to mobilise in February, staff in primary and community care, in social care, in COVID wards and community hubs, in emergency and intensive care, in all professions and in all jobs, and with very little respite so far. Local hubs have been put in place to give members of staff the space to relax and recuperate away from their work environment. The intensive provision of psychological support for staff and carers will continue to be prioritised. And our National Wellbeing Hub is truly innovative, empowering staff and carers to address their physical and mental health like never before. And we've established the new National Wellbeing Line for all health and social care workers based within NHS 24. We've supported the provision of online coaching support and set up a network of 84 wellbeing champions across the country. But our staff need time off, time with their families and time to recharge. So we're working with our partners to develop a COVID-19 supplement to the Integrated Workforce Plan, with a particular focus on ensuring respite for staff who have got us to where we are now. In working to remobilise services, we must also remain alert to the need to provide and maintain safe living and working environments, whether that is in care homes, in GP practices, in assessment centres, in our hospitals, or any other treatment spaces. And we have to make sure that the necessary support is in place to respond to any future increase in COVID cases, whether that means staff training and development, securing supplies of key medicines or devices, or replenishing our PPE stockpiles. And alongside this are the risks associated with a no deal or a limited deal from Brexit, where the end of the transition period lands right in the middle of the flu season and may materially impact supply chains during this critical time. So there are clear and significant operational challenges ahead. In recent years, we have made significant progress under this government's £850 million waiting times improvement plan. But when the waiting times for the period from March to June are published later this month, we can expect to see any progress wiped out, with a very significant increase in the number of patients waiting for routine appointments and treatments. Boards have been cautiously resuming a wide range of routine services, paused in the initial response, and doing so in line with clinical priorities. But many will not be operating the same as before, nor in the same volumes. The numbers of patients who can be seen, diagnosed and treated in the timeframes of before will clearly be reduced by the continuing and necessary infection prevention and control measures, such as altered patient flows, appropriate bed spacing, physical distancing, PPE requirements, and time needed for additional cleaning between clinical sessions. Early estimates are that up to 50% of operating theatre throughput could be affected in the coming months. We will augment local capacity by using national resources at NHS Golden Jubilee and NHS Louisa Jordan, and there will, of course, be variation between boards. But I want to be clear, this will have a significant impact on the time many patients have to wait for treatment. Now, I completely appreciate that further delays can materially affect the quality of life of many who will be waiting for care or treatment, with continuing pain and further anxiety. And I wish it was not so. I regret that we cannot mobilise to the degree and at the speed we all wish for. But as we continue to deal with the virus and the aftermath of the first months, there is no choice. We have to continue to balance the competing demands and pressures, making the best decisions we can, none of which are easy and none of which are taken lightly. So how do we determine what to mobilise and in what order? How do we redesign to ensure we learn from and build on the hard-won lessons of the last few months? What I can promise all patients is that treatment will continue to be triaged and prioritised on the basis of clinical need, in line with advice and guidelines developed and agreed with the Royal Colleges and others. We will be developing a national cancer recovery plan to account for the changes to cancer services specifically and implement innovative solutions. This plan will be led by the National Cancer Recovery Group and published in early autumn. The plan will focus on reducing the inequalities exacerbated by the pandemic and ensure patients are receiving treatment equally using a Once for Scotland approach. But there is also a need to strike a balance between urgent care and quality of life care, which, if left not tackled, creates further long-term problems. So I want to repeat our commitment to resume the full range of pain services as quickly as it is safe to do. We will shortly publish a COVID-19 recovery framework for NHS pain management services to continue to inform and guide our work. This will sit alongside the framework to support people through recovery and rehabilitation that I published last week, and which targets work and services to better understand and help people who have been affected, often profoundly, in their physical and psychological health by their experience of the last months. Deciding what we can mobilise, how we can build in the improvements in service delivery we've seen in recent months, whilst also managing the limitations I have outlined, is a continuous, iterative task. But it is informed by the experience and knowledge of all our key partners, including the RCN, the BMA, our trade union partners and colleagues in local authorities, Scottish Care and Integration Joint Boards, the third sector and clinical stakeholders, including the Royal Colleges. The patient's voice is important too, and we're working with the Health and Social Care Alliance in Scotland to make sure that we hear what matters most to patients. Collectively, all those voices feed into the Mobilisation Recovery Group, which I chair. The fourth meeting of the group took place last week. The group has been meeting fortnightly with much detailed work in between and will continue to inform and guide our decisions. Presiding Officer, there is much more to say and more detail to set out in the coming weeks on elective procedures, our approach to dealing with backlogs, the criticality of primary, community and social care, our plans for mental health support and more besides. As plans firm up, we will keep members fully informed. But I want members to be assured that learning, thought and effort is being applied nationally, regionally and locally to give us as resilient and robust a response possible to the myriad pressures and risks that we face in the coming months. Thank you.
Thank you very much, Cabinet Secretary. Before I move on, can I repeat what my colleague Ms Fabiani said from the chair? This is follow-on business, and at this stage of the parliamentary session, members should be aware they must be in the chamber before the statement begins, and too many came in late. We're beyond the time where you look at something should start at 3. You know it's follow-on, you should be in. Now the Cabinet Secretary will take questions on the issues raised in her statement. I intend to allow 45 minutes for questions, after which we'll move on to the next item of business. It would be helpful if those members who wish to ask a question were to press the request to speak buttons now. And I call Donald Cameron to be followed by Monica Lennon. Mr Cameron, please.
Deputy Presiding Officer, can I apologise for being one of those people who arrived late in the chamber? Can I thank the Cabinet Secretary for advance sight of her statement and the update? And I too would like to pay tribute to our incredible NHS staff and social care staff for all that they have done and continue to do. And as the Cabinet Secretary rightly acknowledges, this virus has not yet disappeared and we must remain vigilant as we continue to fight it. Her statement explicitly refers to routine testing of people who work in care homes. And we remain concerned that testing of care home staff for COVID-19 remains unacceptably low. In July, the Cabinet Secretary said on several occasions that weekly testing of care home staff was in place, and yet weekly figures published by her government show that thousands of care home staff are still not being regularly tested. Indeed, figures published today show that around 16,600 care home staff were not tested. This is completely indefensible and a failure which lands squarely at the feet of the Cabinet Secretary. So can I ask her, with that in mind, 2 questions. Firstly, why are thousands of care home workers still not being tested, despite promises made by her that they were? And secondly, what urgent action will she take to fix this and ensure that every care home worker is regularly tested?
Thank you, Cabinet Secretary.
So there are 2 things that we are doing. The first, in terms of working out how many care home staff should be tested. It is unrealistic on a weekly basis to expect 100% of care home staff to be tested every week, for 2 reasons. First of all, that staff will be on annual leave, they may be on sick leave, they may be on maternity leave, and they may indeed be on different rota patterns. So, in discussions with Scottish Care and others, the percentage that we look to is 70% or more. And in recent weeks, we have overshot that 70%. The other reason is that we have some staff who refuse to be tested. It isn't mandatory. And so working on real-time basis with colleagues in CCP, in Scottish Care and in COSLA, my officials are working through all the issues that may be preventing staff from agreeing to be tested, trying to remove and address those as we go, some of which we have already addressed with the help of Ms Lennon and the amendment that she passed in terms of the special fund to address those staff who were reluctant to be tested in case they were positive because their terms and conditions were such that they would only receive statutory sick pay, a significant decrease in their weekly income for many staff who were on low pay in any event. So we continue to work that through, but I think that the current programme and the over 70%, the most recent figure, not the one that was published today, I don't have that percentage, but the week before was 76% of the total number of staff employed in the care home sector were tested. Bearing in mind that 100% is an unrealistic target, we continue to drive that up. But what we are seeing is the positive impact of that testing in terms of the number of cases that we are seeing in our care homes across the country. The final point, Presiding Officer, quickly if I may, in terms of visiting and easing the visiting restrictions, Mr Cameron, I'm sure, will have studied this carefully, and he will know that one of the criteria for a care home to be able to ease visiting restrictions is that it is fully and actively participating in the weekly care home staff testing programme. That is one of the ways that we try and make sure, with encouragement, that all our care homes are taking part.
Thank you. I call Monica Lennon, followed by Emma Harper.
Thank you, Presiding Officer. And can I also put on record our thanks and appreciation for all of our healthcare workers. And I thank the Cabinet Secretary for advance sight of her statement today. Back at the end of May, we welcomed the framework to remobilise, recover and redesign our NHS. And we appreciate that a bit of time would have been required, and of course that staff need some time off. They're burnt out. They were burnt out before COVID, but that's got a lot worse. But Cabinet Secretary, it has been very slow, and for many of our constituents, for many patients, it feels like the NHS is still in lockdown, and the easing of that lockdown, sadly, has come too late for some of those patients. Can I ask the Cabinet Secretary to give us a bit more detail about what the government is doing to address the chronic understaffing levels and underfunding that was a problem before COVID? Our NHS was running hot and people are really struggling now. And can I just pick up on the issues around the winter flu vaccination and preparedness for winter? I've raised this in recent weeks, but if I give my own health board as one example, NHS Lanarkshire, in terms of the ability to deliver that expanded flu vaccination programme, they've said that that's a very high risk for their health board. And across the country, other health boards have the same worries. And if we're worried about delivering the flu vaccine, how are we going to deliver a COVID vaccine when we get one? So I'd be grateful if the Cabinet Secretary could raise these points, because these are issues that health workers are very worried about, but of course all of our constituents are very worried about too.
Cabinet Secretary.
I thank Ms Lennon for some very important questions there. She is right that there is no part of the NHS that is restarting as fully and as quickly as any of us want. And part of the reason why in my statement I set out all the things that we need to do right now in terms of test and protect and manage those clusters and those outbreaks, the flu programme, the reduction in productivity because we need our NHS to be safe, the additional testing programmes that are underway, is because those are all staffed by NHS staff. And so if we have them all doing that, we don't also have them free and able to do other jobs in the health service that they have now been redeployed to do, albeit that we are actively engaged in bringing more of our health returner portal back in, and some of those most certainly to help us in the flu vaccination programme. So I understand the frustration and the disappointment, particularly from patients and people who have been waiting. Our boards were asked to produce mobilisation plans to the end of July to get going, and they did that. They've now produced, as we asked them to, mobilisation plans to the end of March next year. And they've been asked to make sure that they build into that well-being of staff, respite and care of staff, and that they join that up with the health and social care integration, so they're focusing on primary and community care and not solely in acute. We are working through those. That's part of the job of the mobilisation recovery group that I chair, is to work through those and try and ensure, with the Royal College's input, that we set clear, clinically determined priorities for the whole of the country that boards will then follow, so that we try as best we can to have an equity of access and approach, regardless of where you live in Scotland. On the flu, and one of the ways, a particular example of that is the recent framework for prioritising cancer surgery that has been published with that clinical lead, and we will follow that up in other areas, particularly in elective care and elsewhere. On the flu vaccine, your board and you are absolutely right. It is a significant challenge to vaccinate 2.25 million people before the end of the year. And on the upside, it is an excellent dry run for the COVID vaccine. And so we're determined to get this right, but it will be an all-system delivery. So we will be engaging as many parts of the primary and community care sector as we can. So that will be pharmacists, could be dentistry, could be other clinical teams involved, as well as bringing those returners back in to help us. There's two things that need to happen to assist that. One is that the UK government needs to pass a piece of emergency regulation to change the Reserved Act about who can give a vaccination. And the second is that we enact a part of our coronavirus emergency legislation around the administration and the control of vaccinations. The two need to go hand in hand so that we have that range of people clinically qualified but able to vaccinate. That will allow us to do this. There will be a national delivery plan that boards will feed into, but it needs to be national all system if we're actually going to do it and be ready for that COVID vaccine as well.
Thank you. I certainly don't want to curtail questions and answers, but I've got 40 minutes and 20 questioners, so please bear that in mind when you're asking your question and when we're having responses. Emma Harper, followed by Brian Whittle, please.
Thank you, Presiding Officer. Could the Cabinet Secretary outline how the Scottish NHS can ensure that there is a consistent approach taken to service remobilisation across the country, which includes NHS Dumfries and Galloway in my South Scotland region?
Cabinet Secretary.
I'm grateful to Ms Harper. I think in large measure I've answered that. That is partly through the board mobilisation plans, but it is ensuring that through the recovery group we take a collective view informed by trade union colleagues in terms of representing staff, by the Royal Colleges, by other key stakeholders, our local authorities in the third sector and so on, to ensure that we have a consistent framework for prioritising on the basis of clinical need and for ensuring that services are started and followed through across all our health boards so that we get that equity of access. So we have a national approach but local delivery.
Brian Whittle, followed by David Torrance.
Thank you, Deputy Presiding Officer. Now, I've raised the issue of chronic pain patients with the Cabinet Secretary before. However, for many, it is 5 months since they have been able to attend a chronic pain clinic or access appropriate treatment, some taking the drastic action of travelling to England for treatment, so desperate have they become. And I note that they have repeated a commitment to resume the full range of pain services as quickly as possible. However, Cabinet Secretary, can I ask, despite the report from clinicians entitled Impact Restart Report for Orthopaedic Elective Arthroplasty, suggesting it has been entirely possible to restart these treatments quite safely, the plight of those suffering these conditions has remained largely unheeded?
Thank you. Cabinet Secretary.
So I completely agree with Mr Whittle, and that's why I made a particular point in the statement of mentioning what I describe as quality of life health issues. They are not life-threatening as such, but they have a huge debilitating impact on people's capacity to live as freely and independently and as fully as they wish, as we would want them to be able to do. And pain has to be central in that. So I have an absolute commitment to ensuring that we restart all of the additional pain services that are needed so that people can access those pain services, holistic services, that combination of medication, of physiotherapy, of lifestyle management, all of the things that are very bespoke to each individual. I do not subscribe to the view that medication is entirely wrong in these instances. I think it has an absolute place to play. And we will want to see that. And I have asked my officials not only to produce that framework, but to produce for me the delivery plan that will show me how those pain services can be restarted right across Scotland and how quickly we can do that.
David Torrance, followed by Jackie Bailey.
Presiding Officer, recent ONS stats indicate that the number of adults experiencing depression has almost doubled during the coronavirus pandemic. How will the NHS prioritise resumption of one-to-one personal mental health support for those who need further psychological support in the light of the coronavirus crisis?
Cabinet Secretary.
So I'm grateful to Mr Torrance for what is a very important question, and I know that my colleague Ms Hockey, who is sitting beside me here, is busy producing and agreeing a framework, a remobilisation plan for our mental health services that looks particularly at building on some of the innovative ways of delivering mental health services, both to adults and to young people, that we saw through the pandemic, but also increasing our capacity to deal with those additional areas of demand that will have arisen because of the pandemic, as Mr Torrance describes, but also because of both because of people's experience of the lockdown restrictions, but also the significant psychological trauma we are seeing in individuals who have contracted the virus and have survived, but still have long-term psychological and physical demands needed for their health. And in that particular area, we're making very specific use of the expertise of our National Trauma Network and the psychological innovative steps that they have taken to help patients who have suffered trauma.
Jackie Bailey, followed by Alison Johnson.
Like hospital and social care staff, GPs have been working particularly hard during the pandemic in providing online, email and phone consultations for their patients. But this is not a substitute for face-to-face consultations, and I have constituents that have suffered a significant deterioration in their conditions because they were not seen. Will the Cabinet Secretary ensure that as part of NHS remobilisation, there is much greater access to face-to-face consultations with our GPs?
Cabinet Secretary.
Yes, I will, because although I have spoken before about the innovative steps that were taken in response to the pandemic and the need to create COVID-safe pathways and so on and so forth throughout our health service, and that made much use of, very successfully, of Near Me, for example, and of other digital methods, I know absolutely that is, and GPs will tell me this, other clinicians tell me this, that is not a substitute in many cases for actually seeing the person, seeing their body language, seeing the expressions on their face and the things they're not telling you that you need to question a bit more to really get to the bottom of it. So in talking with in looking at those mobilisation plans, I've asked for a very particular focus to be put onto primary and community and social care. For me, the bedrock of our NHS. And in talking to the BMA, particularly the GP side of that, I know that we will take very particular measures in response to what they're saying to us, as well as the Royal College of General Practitioners, about what more we might do to assist GP practices to remain a safe place, a COVID-free space, so that they can pick up on their face-to-face consultations.
Alison Johnson, followed by Ruth Maguire.
Thank you, and I too must apologise for missing the beginning of the Cabinet Secretary's statement. The Cabinet Secretary advises that those who work in high-risk environments such as care homes will continue to be routinely tested, but that routine testing will not yet apply in schools and hospitals, an issue of ongoing concern to many. So can the Cabinet Secretary confirm if this differential approach is subject to ongoing continuous review by the Scottish Government? Thank you.
Cabinet Secretary.
Yes, it is. What Ms Johnson said is not quite accurate, if I may. So where we have introduced testing for NHS staff in hospitals are in particular areas, long-term care of the elderly and in cancer treatment, as well as one or two others. And I'm very happy to make sure that that I let her know the detail of those. And that was on a basis of advice to us from our CMO advisory group and our very particular nosocomial group. So that was clinical and scientific advice, but it continues to be reviewed. And one of the areas of review, for example, is in terms of emergency department admissions. Those aged 70 and over who are admitted to our hospitals are subject to routine testing, but one of the areas currently being looked at is to widen that to all emergency admissions. In terms of schools, there is test and protect, of course, around schools. There is surveillance work in terms of schools. And we have also made sure that school staff, all school staff, can access testing if they have a concern that they may have been close to someone who may have the virus. So they may not be symptomatic, but the particular portal has been opened up so that they can access that as well. Whether or not there is more that needs to be done, again, the very particular expert group working with the DFM on schools and the safety of schools will continue to look to see whether testing can be used in other ways to assist in the safety and the assurance around schools so that we can continue to keep schools open and young people learning.
Ruth Maguire, followed by Edward Mountain.
Presiding Officer, during this pandemic, people in care homes with dementia have been deprived of the social and emotional contact and indeed advocacy family visits bring. The Scottish Government guidance on care home visiting has a first principle that at all times a person-centred approach must be taken. Can I ask the Cabinet Secretary what more can be done to ensure that this is the case in each and every care home in Scotland, so that we can be sure that our older people get the contact with their family that we know is so crucial to their health and well-being?
Cabinet Secretary.
So this is another very important area. Throughout the pandemic, from the very outset, when we said that visiting to care homes needed to be stopped, we made exemptions for that. And one of the groups of residents for whom there was an exemption were those residents with dementia, where the absence of seeing family or friends was causing additional distress. And care homes were clearly advised what to do in terms of ensuring infection prevention and control and safety in these circumstances, but to permit that visiting. I regret that in some instances that has not happened. I have had individual cases raised with me and we have investigated, intervened and I hope resolved them. However, the increase in visiting which has gone from one designated visitor outdoors to up to 3 outdoors and currently looking then at, provided the right plans are in place, a designated visitor also indoors, I hope will further assist this alongside what I am currently looking at, which is guidance around safe increase in communal activity, but also the reintroduction of other health and support services to care homes that are particularly important to residents and which they have not been able to access in a face-to-face way up until now. Again, that will be slower than before. That will take longer than it has done before because we need the proper PPE steps in place and all of that. But I hope that step by step, with all of the safety precautions in place and with care homes who are COVID-free and participating in care home worker testing, that we will be able to reintroduce greater levels of normality to the residents in our care homes.
Edward Mountain, followed by Fulton McGregor.
Thank you, Presiding Officer. Before the pandemic, there were only just enough beds in Raigmore. Now there aren't. Given that this is one of the main factors limiting the amount of operations that can be carried out, will the Cabinet Secretary agree to commit to providing additional temporary accommodation to allow the backlog of in-hospital treatments and operations to be carried out in the Highlands?
Cabinet Secretary.
So, additional accommodation isn't just going to the nearest Premier Inn and opening it up and buying all the bed spaces. We're talking about accommodation that needs to be clinically safe for patients and staff to work in. So that's a really important caveat to say, to put in place before I respond to Mr. Mountain's question. Every single health board is looking at what they can do to maximise the space that they have, the use of their theatres, bearing in mind that they need to take very necessary infection prevention and control measures, one of which is distancing, and that is affecting Raigmore as well as other hospitals in terms of spaces between beds and so on. But NHS Highland is actively looking at what more can it do in order to increase the number of patients that it can see and treat, but at the same time remembering that it has other demands in front of it, not least of which is the work to continue to keep the virus under control and the important work to allow staff time to recover before we ask them to do even more than we have asked them to do up until now.
Fulton McGregor, followed by David Stewart.
Thank you, Presiding Officer. Can I ask the Cabinet Secretary for an update on the review of domiciliary eye care and when she thinks it may be safe for face-to-face domiciliary eye care services to resume in some capacity?
Cabinet Secretary.
So that is one of the areas of service that is currently being considered for reintroduction to care homes, for example, but is also domiciliary eye care to people's homes, and that will be wrapped up in that piece of guidance. I would hope that we will be able to approve that and see those services reintroduced shortly. But all of that, of course, depends on how we see the prevalence rates of the virus run across the country, the levels of infection, what happens to the R number and the numbers in hospital and in ICU and so on. So all of these are really important NHS services, really important to restart them, but they sit in that context and they must be started safely.
David Stewart, followed by Annabel Ewing.
Thank you, Presiding Officer. In the Cabinet Secretary's statement, there is a positive references to remobilising the NHS and patients to receive equality of treatment. For my Hands and Islands constituents, there's two main issues: provision of a PET scanner for cancer treatment within the region and dynamic and effective pain clinics. Would the Cabinet Secretary agree that the two above issues would be consistent for a once for Scotland approach?
Cabinet Secretary.
So it certainly is the case that we need to increase and do as best we can to increase access for patients to those healthcare services in our island communities as well as in the remote and rural communities. We have just agreed additional investment in diagnostic equipment. I do not know, standing here, where it is going, but I'm very happy to investigate exactly where it is going and make sure Mr Stewart knows that. And if there's a particular issue in terms of that PET scanner, to take that up with my officials. But I agree with him that we need to make sure that we have equity of access as far as we can manage it across the country for the services that we can remobilise.
Annabel Ewing, followed by Sarah Boyack.
Thank you, Presiding Officer. On the important issue of the plans for a significantly enhanced seasonal flu vaccination programme, can I ask the Cabinet Secretary how the NHS will manage the balance between providing seasonal flu vaccinations to such a significantly increased cohort of people, whilst at the same time working to prevent the spread of COVID-19?
Cabinet Secretary.
So this is an important question. It's an important question for those that will be eligible for the flu vaccination to know that where we are asking them to go to be vaccinated will be as COVID-free as we can assure them it is. Just as we did in creating the COVID pathway in the community with the COVID assessment centres and the hubs, taking that stream of work out of the GP practice. We're looking to replicate that for the flu vaccination programme, and that will mean that we are currently across the country, all our health boards and Public Health Scotland are looking at other locations where people can go to be vaccinated. And some of those will not be healthcare locations, so we need to make sure that they're accessible, that they have all the levels of cleanliness that we need, all the infection prevention and control measures that we need, so that we can vaccinate large volumes of people, accessible not only in the physical sense, but accessible in the sense of not requiring long car journeys or whatever to get to them. So that work is well underway because we want to be able to start the flu vaccination programme in time to have completed it by the end of this calendar year.
Sarah Boyack, followed by Alec Cole-Hamilton.
Cabinet Secretary, in April you announced a much-needed pay rise for care workers, but without any additional funding. Given that the Edinburgh IGB has been underfunded from its inception, there is now an unacceptable choice between cutting services desperately needed for pandemic recovery and funding this vital pay rise. So will the Cabinet Secretary fully fund the pay rise she announced in April?
Cabinet Secretary.
Well, I'm afraid I don't accept the premise of Ms Boyack's question. There is additional funding. In fact, there is not only additional funding to fund the pay rise, there is £100 million of additional funding available to social care to make good the additional cost to them of responding to the COVID pandemic. That is in addition to the PPE that we have been making free of charge to that sector. The Edinburgh IJB is actually alone in IJBs in not paying that wage rise. Other IJBs are doing it. So clearly, the funding is available. IJBs need to make political choices like governments make political choices. The money is there, and I can assure you that I intend to have even more discussions with the Edinburgh IJB about why they consistently refuse to make the right choice and pay those workers the money they are due and back pay it to the 1st of April.
Alec Cole-Hamilton, followed by Rona Mackay.
Thank you, Presiding Officer.
The Cabinet Secretary's statement drew heavily on the COVID-19 statistical report. It is disappointing, however, that she left out the update on quarantine checks for international travellers, which is deeply troubling. Hamza Yousaf told this Parliament that 20% of those expected to quarantine would be contacted. Yet we now know that the traces are following up with only half that number. But more worryingly, Presiding Officer, it reveals that traces are unable to find a large portion of those supposed to be in quarantine. Can I ask the Cabinet Secretary how it is that we are getting this so wrong?
Cabinet Secretary.
I'm looking to see the most recent data that I do have, and my apologies, I can't instantly lay it to hand. But my understanding, and I will correct both the record and Mr Cole-Hamilton if I am wrong in this, is that our staff, our officials through Public Health Scotland are reaching that 20%. Now, what is also the position, though, is that if they cannot reach an individual who should be quarantining, either by the second or the third phone call or by email, that they then pass that information on to Police Scotland for Police Scotland to then take whatever operational decisions they think fit. That is the right thing to do because quarantining is critically important, and the 20% that should be getting contacted from the numbers. And of course, that will vary week on week, depending on the numbers of incoming travellers from the countries that are not exempt from quarantine. But that is a really important part of what we are doing. And my understanding is the numbers are meeting that 20%. I will check those figures and I will make sure that both Mr Cole-Hamilton knows what they are, but if I am incorrect, I will correct the record here for the Parliament.
Rona Mackay, followed by Bill Bowman.
Thank you, Presiding Officer. Can the Cabinet Secretary give an indication of whether the breakup of Public Health England will have any impact in Scotland's response to the pandemic?
Cabinet Secretary.
I'm afraid the short answer to that is I do not know for certain whether it will make a difference or not, and if it makes a difference, whether that will be a good difference or a less than good difference. I had a conversation with the Secretary of State, Matt Hancock, on Monday night, where he informed me and my colleagues in Wales and Northern Ireland of his intention to make those changes. His assurance was that there would be no difference in terms of who acted on what reserved and devolved responsibilities. We need to look further at the detail of that and make sure that in operational terms, not just about who has responsibility for what, but my officials knowing who they're talking to south of the border in this new organisation, given the relationships that would have been established with Public Health England, those relationships are really important about the speed of transfer of information and so on. So we need to continue to look at this in detail. And if there are issues that I think will affect adversely on Scotland, then I do have that very regular call with my colleagues in Wales, Northern Ireland and Mr Hancock, and the member knows that I will raise those issues there.
Bill Bowman, followed by Stuart McMillan.
Thank you, Presiding Officer. Clearly, for the future, we should learn from the past. It was a patient who tested positive and then was allowed to be released from a hospital into a care home, who was the first care home COVID death in Angus in my region. How will the Cabinet Secretary ensure that she is better informed to take decisions in the future than perhaps she was in the past?
Cabinet Secretary.
I think there are a number of ways by which we are learning lessons as we go, partly informed by the growing knowledge and understanding of coronavirus that our leading scientists and clinicians have, not just those working in government, and I'm very grateful to them, and through the advisory working from academia with us, but others elsewhere who are working very hard on this here in Scotland, in the rest of the UK and in Europe and elsewhere. So as the understanding of the virus develops, we aim to change our guidance and our approach accordingly. And so one of the other ways by which we have learned considerably is, I think we started off very well in terms of our National Procurement Service and its stockpile of PPE, but its modelling work has improved significantly. So I am very confident in the modelling that it is doing in estimating demand for PPE, along with Mr McKee's significant work in securing domestic supply of PPE, that we know what we need and where we're going to get it and how we're going to get it. We've continued with our orders of ventilators, for example, so that we will have quadruple the number we started out with, ready should we need those, but stockpiled if we don't, and ready to replace as existing ventilators need replacement. And our testing strategy has been updated, and that is in direct response to that growing knowledge of the virus and to learning the lessons and the improvements that we need to make as we go.
Stuart McMillan, followed by Polly McNeill.
Thanks, Presiding Officer. Can the Cabinet Secretary outline how the NHS Liaison Jordan is and can be used to help the delivery of NHS services?
Cabinet Secretary.
So, as I think the member knows, the NHS Louisa Jordan saw 400 patients receive orthopaedic and plastic surgery consultations, and we're now looking at key diagnostics such as X-rays, CT scanning, ultrasounds, as well as special dermatology, outpatient appointments, and continuing, of course, orthopaedic, plastic surgery, and so on. So the Louisa Jordan remains a significant resource, and as I said in my statement, alongside Golden Jubilee, which has restarted all of its services, particularly in the area of elective, and my understanding, and they deserve huge congratulations for this, undertook 10 transplants in the period since the 1st of April, so right through the middle of the pandemic. That COVID-free national resource undertook 10 heart transplants. So we will continue to look at how we can use and maximise the use of the Louisa Jordan, bearing in mind that we need to always be able to return it quickly to cope with any surge in COVID patients that our long-term estate cannot cope with, although my expectation is that we will be able in our NHS to cope with any upsurge in numbers that we see, provided we continue to hunt down the virus, suppress it, and retain the trust and the confidence of the population in Scotland to follow the measures that we ask them to follow.
Polly McNeill, followed by Willie Rennie.
Thank you, Presiding Officer. Cabinet Secretary, you said in your statement, what I can promise all patients is that treatment will continue to be triaged and prioritised on the basis of clinical need, in line with guidelines with the Royal Colleges. Many doctors have preferred clinical judgment over waiting time targets. So I wanted to ask you, how regularly do you think these arrangements could be reviewed? Because am I right in saying that in effect waiting time targets would be on hold? And in view of that, could the Cabinet Secretary offer any assurance to patients to ensure that they have some transparency in clinical decisions on when they are seen by doctors?
Cabinet Secretary.
So I think clinical judgment is really critical. That's why I keep going on about the importance of our engagement with the Royal Colleges and point to the example, which we will repeat in other areas, of the National Clinical Framework for Cancer Surgery, which is entirely led by those clinicians and their judgment on what are priorities and what aren't. So I agree with Ms McNeill in that regard. In terms of elective work and our waiting times and so on, I intend to return to the Chamber with more detail on that, as I said towards the end of my statement, once we have worked with all our boards and the relevant clinical teams, because it's whole teams, it's not just doctors, the relevant clinical teams about what is possible and how will that be delivered. And part and parcel of that, she is so right, is absolute clarity and transparency with patients about what they can expect and when they can expect to hear from their board about their times and their dates and so on. And this time, we will make sure that that is a clearly national-led exercise. Boards will do the work, and they know their patients and they know their numbers and they know how to get in touch with people and to make sure of what patients need to know. But I need to be sure that patients are being told, all patients by all boards, that patients are being given really clear information in language that is easy to access and understand.
Willie Rennie, followed by Alistair Allen.
The Health Secretary will need to correct the record because she's wrong about the number of people in quarantine that are supposed to have been contacted. It's supposed to be 20% in the last week. It's 14%. Since the end of June, it's been 10%. So it's just not good enough. What is the Health Secretary going to do about this? Because the quarantine contacting is very important.
Cabinet Secretary.
So what I'm going to do is I'm going to look at the numbers Mr Rennie has just given us alongside his colleague Mr Cole-Hamilton, look at the numbers that I have here, correct the record as I promised I would do if I am wrong, and I have no reason to gainsay Mr Rennie at this point. And if Mr Rennie is right, I am then going to talk to Public Health Scotland about exactly what the issues are and the problems are that are preventing them from meeting that 20% target, and what steps we can take to ensure that they do, and then advise members of what I have done.
Alistair Allen, followed by Neil Findlay.
The Cabinet Secretary will be aware of the interest regarding the testing of workers in the oil and gas sectors. In my own constituency, there have been COVID-19 cases from returning offshore workers, and the recent outbreak in Aberdeen will naturally, as she knows, heighten those concerns. Will the Scottish Government consider any further steps to test more returning offshore workers in light of the situation in Aberdeen?
Cabinet Secretary.
So I'm grateful to Mr Allen. As he knows, it's not currently the advice of Public Health Scotland to routinely test asymptomatic offshore workers. And that is in large part because those about to travel offshore, having been tested, wouldn't remove the risk of people incubating the disease, then becoming symptomatic whilst offshore. However, as I've said more than once, I think, today, our clinical advisory group and our Chief Medical Officer and National Clinical Director and others continue to assess and review our testing approach. And again, I will return to this issue with them and ask for their current advice on whether that has changed, and if it has not changed, in what way would the rationale for the absence of change be best set out, and make sure that I can return to Mr Allen with that answer.
Neil Findlay, followed by Miles Briggs.
NHS boards and IJBs insist the eradication of delayed discharge almost overnight in February was due to improved joint working and the sharing of best practice. Presumably, they will continue to work jointly and share best practice now. And if that's the case, can the Cabinet Secretary confirm that there will be no return to the huge numbers of people stuck in hospital and being misled into believing that they are in hospital still because no care home place or care package can be found for them?
Cabinet Secretary.
So I think NHS boards and IJBs are correct in what they've said. And in the regular meeting, fortnightly I think it is, with my colleague Councillor Curry, who's the social care spokesperson for COSLA, one of the areas that we continue to look at is the numbers of delayed discharge, and working with his officials and mine, with the IJBs and with the boards, looking at what more we can do in terms of sharing best practice. One of the groups of people who are in the remaining delayed discharge cohort, if you like, are adults with incapacity, and also a group of people who have complex mental health, learning disability and social care needs. And so a great deal of work is underway. Not every health board seems to experience difficulty in working in terms of adults with incapacity who no longer need to be in a clinical setting, but some do. So we are working with those to see what their particular difficulties and obstacles are, to try and overcome those. And in terms of what I would think of as high volume, high complex social care needs, again, the work that we began before the pandemic on the reform of adult social care, and that we are continuing with Councillor Curry and his colleagues in local government, we are continuing to take that forward to see in what way we can assist the provision of social care packages for those with the most complex needs, but who do not need to be in a clinical setting and who should be able to live in the community as independently as it is possible for them to do and as independently as they wish.
Last question from Miles Briggs, please.
Thank you, Deputy Presiding Officer. I welcome the restarting of the Pain Services Cabinet Secretary, but throughout the COVID scandal, we have not seen the opportunity for families to be given advocacy. Now, I raised this with the First Minister a couple of weeks ago. She said she would write to me, but she still hasn't. So I'd be grateful if you could look into the establishment of a fund for families. But the point I want to ask today is, will the Cabinet Secretary outline whether or not she supports the establishment of a patient commissioner? Will she agree to consult on that and report back to Parliament?
Cabinet Secretary.
So, two things to Mr Briggs. Nice to see him back. First of all, there is no COVID scandal. I don't know exactly what he's referring to. But if I was an NHS or a social care worker watching this statement and discussion in the Parliament, I think I'd be pretty appalled at the notion that all the efforts that I had put in were to be described as a scandal. If Mr Briggs wants to be critical of this government, he should feel free to do so, but he should be clear that that is what he's being critical of. In terms of what needs to be done, then I'm very happy to look at where we are in terms of the advocacy point he raised with the First Minister. In terms of the Patient Commissioner, if his reference there is to the Cumberledge report, then I've already said to his colleague, Mr Carlow, to Mr Finlay and to Mr Neil in an earlier discussion that we were having that I was very sympathetic to the idea of a patient commissioner. We needed to look at how that fitted with our overall Scottish patient safety programme, globally recognised as an exemplar. And I will return to that in due course in the debate that I have committed, the government debate that I've committed to having on all of the measures in the Cumberledge report and our response to them.
Thank you very much. That concludes questions on the statement. I thank all members who managed to get through all the questions yet again, and there will be a slight pause where we move on to the next item of business.